Tuberculosis of the WHO Europe. My name is Elmira Gurbanova. I'm the coordinator of this Virtual Medical Consilium. Today, we are going to discuss a very sensitive topic, namely treatment of drug-resistant TB during pregnancy. We'll have 3 speakers, and during their presentations, we would kindly ask you to leave your questions in the chat. And after the presenters stop, we will have a Q&A session. This webinar will be held in Russian with interpretation into English, and you can select the language you prefer for both the audio and the slides. And you can also download the recordings. We will also publish the link of this webinar's recording a bit later on. I would like to pass the mic to Oleksandr Korotych from WHO Europe, who will present some technical details on selecting the language and the language of slides.
Спасибо большое, Эльмира, уважаемые коллеги. Мне поручили такую важную миссию рассказать про то, как технически правильно выбрать наши переводы. У нас есть 2 вида перевода. Первый — это устный перевод. Внизу вашего экрана Zoom есть такой глобус, значок, где вы можете выбрать язык перевода. У нас русский и английский. Наши презентеры сегодня будут говорить на английском языке первые 2, и потом на русском. Поэтому вам необходимо выбрать русский язык для перевода. Второй момент — это то, что у нас все презентации сегодня будут дублироваться также на 2 языках, на английском и на русском. Вверху вашего экрана Zoom у вас будет значок, вы видите экран, вы просматриваете экран, и рядом с ним будет настройки просмотра. И нажав на настройки просмотра, вы можете выбрать экран спикера, того, кто говорит в данный момент, либо же перевод его слайдов на другой язык. Первые 2 выступающих будут показывать свои слайды на английском языке. Вы можете следить за этими слайдами на английском, либо же выбрать экран Марии Рюнстром, которая будет показывать слайды на русском языке. И последняя презентация будет на русском языке. Если вам нужен перевод на английский, вы сможете выбрать соответствующий язык. Мы также продублируем эти инструкции в чате. Спасибо большое.
Without further ado, I would like to pass the mic to Dr. Askar Yedilbayev, who is the team lead of the Joint Infectious Disease Department at WHO Europe. Askar, the floor is yours. Thank you very much, dear Elmira. Dear colleagues, we are very glad to welcome you at our next 21st webinar of the Virtual Medical Consilium of the WHO Europe. And at today's webinar, as Elmira has already mentioned, we are going to discuss a very important topic, which will help you in your good clinical practice. Among recently published updated guidelines on the treatment of drug-susceptible and drug-resistant tuberculosis, we have invited distinguished guest speakers, many of whom are well known to you, who will share this most recent updated information on pregnancy and treatment of tuberculosis. I would like to welcome you once again. I would like to wish you very fruitful work at the webinar, and hopefully it will turn out to be really useful. Thank you. Askar, our first speaker of today, Dr. Jenifer Furin from Harvard Medical School, Department of Global Health and Social Medicine. And she is also the head of the Sentinel Project on drug-resistant tuberculosis in children. She will speak about key principles of management of drug-resistant tuberculosis in pregnant and the peripartum people based on the updated guidelines. Dr. Furin, the floor is yours.
Thank you so much, Elmira, and thank you, Askar, and thank you to all of you, dear colleagues, for joining the webinar on this important topic, and more importantly, for all the work that you're doing every day to provide care to people living with tuberculosis and drug-resistant tuberculosis. My name is Jenifer Furin, and I'm a tuberculosis doctor. I've been working with people who are living with drug-resistant tuberculosis for the last 30 years. And today I want to talk to you a little bit about the care of pregnant and peripartum people who are living with drug-resistant tuberculosis. In terms of an overview, what I first want to talk about are some of the challenges that are faced by people who are pregnant or who've recently delivered and who are also living with drug-resistant tuberculosis. And then I want to describe some of the best clinical practices that have been developed for the diagnosis, prevention, and treatment of drug-resistant TB in this population, as well as among their infants. And I hope that after today, we'll be able to identify each other as colleagues who can help advocate for pregnant people who are living with drug-resistant tuberculosis and who can turn to each other for how to optimize the clinical services we provide for this very vulnerable population. So we know that pregnant people with TB are a very complex population. They're underserved and they're at high risk. Because of the immune system changes that occur with pregnancy, we know that there's an increased physical vulnerability to all forms of TB, and this includes drug-resistant tuberculosis. But we also know that pregnant people are usually excluded from studies of newer tuberculosis drugs and regimens. So as a result, there's often a real lack of access to some of the innovations that have been leading to great improvements in drug-resistant TB care. So as many of you who've been working in the field for a while know, the last decade has really been revolutionary in terms of how we care for people who are living with drug-resistant TB. But in almost all of the studies, including the operational research protocols, pregnant people are not included. And so when it comes to making recommendations for newer regimens and newer drugs, including the all oral shorter regimens, what you'll see is that there's a real lack of evidence on pregnant people. And so a lot of times the guidelines will say things like, you know, no information is available to guide the care of pregnant people, or limited data are available. And what this means is that we're often using very old practices to care for pregnant people. And this is a real problem because there's a real double standard. These people are at increased risk of TB, including drug-resistant TB, but they're less likely to access innovation. And then on top of that, there are a host of sort of psychological and clinical practices that we've adapted over time that really don't serve pregnant people and their families very well. So one of these is that we often use fear-based infection control practices. When you talk to pregnant people about their experience during labor and delivery and after their infants are born, or even during the whole spectrum of receiving perinatal care, they'll describe being treated poorly. They'll describe being treated, you know, they'll be isolated. People won't check on them. And they have some real harmful practices during delivery. Oftentimes their infants are taken away from them unnecessarily, as it turns out. And so this leads to a real challenge for new families during a vulnerable time. And we often optimize the practice of honesty in how we talk to pregnant people about their care, while minimizing the comfort that we provide to them. So we'll say to pregnant people, gosh, I don't know what's going to happen if you take Bedaquiline during pregnancy, or gosh, we don't know how these drugs might affect your baby. And while that may be true that there's limited information along those lines, this often leads to very heightened anxiety among pregnant people. You know, women and people that I've worked with have said, you know, the doctors would say, well, we don't know, the baby might be born with a lot of problems. And that leads to a lot of fear. When in fact, we can almost always reassure pregnant people that the experience so far with treatment X or, you know, regimen Y has been positive. And so our counseling has not really been good at supporting pregnant people. And the result of all of this is that pregnant people with drug-resistant TB often feel confused, They feel scared, they feel isolated, they feel alone, and they feel quite a bit apart from the medical system. And this is really not great care that we're providing. So what do we do about this? We know that there's a limited evidence base, although my colleague, Marian Loveday, who'll be speaking next, has done some really groundbreaking work on including pregnant people in studies, particularly of the newer, more effective and safer drugs. But what do we do when we don't have studies? We don't have a lot of evidence base. How do we improve the practices that we use to care for pregnant people? And so a group of us came together who have experience caring for pregnant people to try to develop some best practices that we could share with each other and share with others in the global community. This is different from a guideline development process, and I really want to emphasize these are not guidelines because there isn't an evidence base that we can use to develop guidelines, but rather sort of a community expert consensus. And we came together, there were 17 of us with collective experience caring for hundreds of pregnant women with DRTB all over the world. And we tried to develop what we call a series of community best practices. So to do this, we went to the literature to try to see what's been published about the care of pregnant people with drug-resistant TB. But when data were lacking, we really tried to reach consensus through processes of discussions, consultation, etc. And this group was hosted by the Sentinel Project. And the Sentinel Project is a group that started 12 years ago to develop best clinical practices for children with drug-resistant TB. And so we utilized the same mechanisms to try to develop a set of best practices for pregnant people with drug-resistant TB. And we focused on drug-resistant TB, but the practices that I'm going to discuss with you all this afternoon actually also apply to drug-susceptible TB. And so please keep that in mind. These aren't just for pregnant people with drug-resistant TB. And what we came out with is a field guide that we have published on the Sentinel Project website. This was launched in South Africa in 2022. And we're working on getting a Russian translation of the field guide now. But the field guide tries to establish global best practices for the care of pregnant people with drug-resistant TB. And it covers multiple topic areas, including diagnosis and pathways to care, treatment regimen design and initiation, and that's what we're going to focus on in this webinar. It talks about monitoring during treatment, management of the pregnant person during labor and delivery, because this is a very vulnerable time for pregnant people. The postpartum management of the person who's given birth, the postpartum management of the neonate. It talks about infant feeding considerations, family planning and reproductive health services, as well as counseling and support. And we tried to provide in here some annexes with practical tools such as referral letters, pharmacovigilance forms, and then we did try to provide the references of the literature that's out there. And so the format of the field guide is we try to present the evidence as it exists, then we review recommended best practices. We try to provide tables with dosing information and practical information. We talk about key summary points, and then we review actual patient management scenarios. We present them as they happened and then try to present best practices. We do attempt to use inclusive language throughout, and we've been advised by people that the term pregnant people is the preferred term. And so because we wanted the guide to be inclusive, you'll note that we try to use inclusive language throughout. And we really came up with several key top-line best practices. And I really want to emphasize these because I think they get lost sometimes. I think a lot of us who care for people with drug-resistant TB, we have a lot of anxiety when we're caring for pregnant people because we're worried about the pregnant person, we're worried about the unborn baby, and we tend to lose some of our key practices. And so we really wanted to emphasize that all pregnant people have a right to the following things. And the first is that they really have a right to free family planning and reproductive health services at all stages of DRTB care, from the diagnosis through the treatment. And this is really so that people with drug-resistant TB can be in control of their reproductive lives and their reproductive health. Having drug-resistant TB is very stressful. It may not be the optimal time, to think about pregnancy and family planning, but we really should be offering family planning and reproductive health services to any person who has drug-resistant TB who can become pregnant. This should be a routine part of our care. And this should include access to things like birth control, pregnancy screening, and then if people are pregnant, frank and supportive discussions about what they would like to do in terms of continuing their pregnancy. Pregnant people also have a right to all the WHO recommended diagnostic tests. So if someone is pregnant and you're concerned that they have drug-resistant TB, they should have access to things like Expert and LPA and culture, but they also should have access to chest X-ray. Sometimes pregnant people are not offered chest X-ray because there's concerns about the risk to the fetus, but a chest X-ray is a very low risk procedure, and pregnant people should have access to chest X-ray both for screening, diagnosis, and treatments. We need to offer all pregnant people compassionate counseling, not judgmental counseling, not counseling that frightens them, but compassionate counseling where we support them in making a decision about either continuing the pregnancy or terminating the pregnancy based on their preferences and their needs, and not based on our fears or our wishes. And we really need to offer pregnant people effective treatment, including the newer drugs. So pregnant people really should be offered access to the more effective drugs, the shorter regimens, and drugs like Bedaquiline, Delamanid, Linezolid, and the fluoroquinolones. And again, the next talk by my colleague, Marian Loveday, is going to emphasize her experience and other colleagues' experience using these drugs. But even when there's specific data on pregnant people are lacking because they have not been included in studies, we still need to offer them access to the most effective regimens. There are some exceptions to this because there are some drugs that may cause specific reproductive toxicity or clear damage to the developing fetus. So these are the injectable agents and then pretomanid, but we'll talk about that more in a minute. So all pregnant people have the right to routine monitoring to ensure that treatment is progressing well and that side effects are being assessed, managed, and minimized. We know that pregnant people may have an increased risk of some side effects, either due to their pregnancy or the impact of medication on pregnancy, nausea and vomiting being a big one, particularly in the first trimester. But a lot of pregnant people will tell you, I didn't know if it was a side effect from the medication. I didn't know if it was because of the pregnancy. And so pregnant people may need more monitoring and they need support to attend their clinic visits and to be monitoring. Pregnant people with drug-resistant TB also have a right to skilled medical care and support during all phases of pregnancy, including delivery. We know that it's often obstetrics and gynecologic colleagues who are delivering the babies. They may not be as familiar with the management of drug-resistant TB. And we know during labor and delivery, pregnant people are often denied access to their medications. They're often not attended during pregnancy. And so it's really important that we do delivery planning with the pregnant person, with her support network, and then with our colleagues who'll be delivering the baby so they understand how to manage a pregnant person with drug-resistant TB. And it's pretty straightforward. For the most part, they should continue their medications. And for the most part, there is not a need for any heightened infection control practices as long as the pregnant person is on treatment and has been on treatment for at least 7 to 14 days. And in the field guide, we lay out a very clear sort of stratified infection control approach because oftentimes these people are managed according to fear-based infection control practices, and that's not necessary. So we know that pregnant people also have a right to access their newborn child and to feed that child in a way that promotes the health of the child and that aligns with the parents' values, preferences, and needs around feeding. In most places, this will mean breastfeeding, and breastfeeding is not contraindicated. So pregnant people who've delivered an infant and who are on treatment for DRTB can usually breastfeed that child without any additional concerns or worries. And there's no need in almost every case to separate the child from the parent. So taking a baby away is a big deal. And we do it too frequently, and we need to stop routinely separating pregnant people and their children. And we need to support the pregnant person to remain on DRTB with practical information about the risks and benefits. In terms of regimen design, I just want to emphasize that even though there may be limited data on the newer drugs and regimens in pregnant people, we can still use them. Really, the use of Group A and Group B drugs save lives and lead to better outcomes. And pregnant people should be getting Group A and Group B drugs. Pregnant people should be given all oral shorter regimens using the same criteria that are applied to non-pregnant people. We need to avoid drugs that have clear harms during pregnancy. So amikacin, for example, we really should not routinely be using amikacin during pregnancy because of the damage both to the maternal ear, but also to the fetal ear. Ethionamide and PAS, their use should also be minimized during pregnancy because of the nausea, the vomiting, and the risk of neonatal hypothyroidism. But if these drugs are needed to save the life of the pregnant person, they can be used during pregnancy and monitored. Pretomanid is also a drug that is not being used right now during pregnancy because there's a risk of testicular toxicity. We're hoping to see the data on the reproductive safety of pretomanid by the end of this year. And there is some experience using it in pregnant people. Pregnant people should also be included in operational research and clinical trials. At the very least, if a person is on a clinical trial and they become pregnant, they should be allowed to continue on that trial. And that did happen in the Practical study and the NTB study, but we need to do a better job including pregnant people in research. And my colleague, Marian Loveday, who'll be speaking next, is a real champion in this regard because we need to understand how to optimize the use of the newer drugs in pregnant people. And there's really no clinical reason to leave pregnant people out of the use of all oral shorter regimens. So for most pregnant people, we recommend that they be used, the pregnant person be monitored, and the experience be shared. So I just, my colleague Marian and I worked with a team to develop this sort of schematic that, I'm sorry, it's a busy slide, but it just tries to look at the journey of a pregnant person and some of the challenges that person faces when they're diagnosed with TB and drug-resistant TB. They may feel initially quite overwhelmed and lonely. They're not sure, should they keep the baby? What will the drugs do to the baby? Who can they talk to? They may worry the pregnancy isn't progressing. They miss some of their medication because they're worried about side effects. They may have some bad experiences with the healthcare system where the antenatal service providers are telling them things about the safety of the drugs, where the DRTB providers are telling them we're not sure about things with your baby. If the baby is born in a facility, the woman might be isolated during the delivery or afterwards. And this often leaves a new family in an exciting but stressful time, feeling exhausted. The baby may not be sleeping after birth. The pregnant person or the person who just delivered may have a lot of anxiety and not a lot of support. And this can lead to disengagement with the healthcare system. And if you look on the bottom at best practices, we try to note where if we can provide supportive counseling and care, we can encourage adherence and reassure pregnant people about the safety of the medications, that even though there isn't a lot of evidence, the evidence that we do have shows that most pregnant people and their babies do very well. We can plan for delivery, make sure that everybody's on board, and that the pregnant person feels they're being cared for in a supportive environment. Using shorter, more effective regimens means that treatment may be finished by the time there's a delivery, and an overall positive experience will ensure that the pregnant person, the newborn baby, and the family continue to engage in care. So we need to continue to advocate for pregnant people, to include pregnancy data in the routine indicators we're collecting and reporting both to the WHO and nationally. We need to take this information that I've just shared and maybe develop some shorter policy briefs, come up with some training modules and counseling tools, and to continue to advocate for this vulnerable population, because most pregnant people who are living with drug-resistant TB do very well. they go on to deliver healthy babies, and that that we can be positive and reassuring, but that we really need to approach this from a more compassionate and partnership view and offer pregnant people the same innovations that we're offering others. So I'll stop there and just say thank you to all of you again for the work that you're doing. And I'm looking forward to the rest of the presentations. Thank you.
Огромное спасибо, Дженнифер, за очень интересное.
Thank you, Jenifer, so much for such an interesting summary of all the key aspects of managing drug-resistant TB in pregnant people. Thank you for referencing this document, the document which in great details describes all the aspects of management drug-resistant TB in pregnant people. We've published this document in the folder. You can access it using the link.
Как Дженнифер сказала, перевод на русский в процессе. Как только будет перевод на русском, мы также циркулируем среди наших участников вебинара. Огромное спасибо, и не теряя времени, я передаю слово нашему следующему спикеру, доктор Marian Loveday. Это старший научный сотрудник отдела исследований ВИЧ и других инфекционных заболеваний Южноафриканского совета медицинских исследований из Южной Африки. Доктор Loveday известна своими исследованиями воздействия бедаквилина при беременности и кормлении грудью у женщин с рифампицин-устойчивым туберкулезом. И это уникальная возможность услышать про...
And this is a unique opportunity to find about findings of her research. So, Dr. Loveday, the floor is yours.
Hello to you all, and thank you for this wonderful opportunity to be with you this morning. Can you see my presentation? Is it in the correct mode?
Marian, no, we don't see your presentation. So far, we only see Russian version, but you should launch yours as well, please.
Let's try again. Right, how's that?
Yeah.
No, it's not yet there. Are you sharing through Zoom? You should open your Zoom screen and then put share screen and then select your presentation.
That's what I'm trying to do.
It says Maria's screen is still...
yeah, but we have a parallel screen showing.
Oh, brilliant.
So,
Any luck yet or not?
Let us see. No luck so far.
Okay, let me try again. What am I doing wrong here?
Share screen.
Hang on, let's try this one.
Пока идет логистическая задержка, я предлагаю и приглашаю...
While we are trying to resolve this issue, I kindly ask our participants to ask questions in chat. We see some first questions regarding the webinar. Please make sure to ask all your questions before we start question and answer session.
Sorry, Mariana, I didn't hear you.
No, I'm just talking to myself about my limitations here.
Maybe, Elmira, maybe you could share the English version on behalf of Marian.
Okay.
Marian, would that be fine? You just then say next slide once Elmira launches the presentation.
Is it still not showing?
No, unfortunately, no.
Okay, and we're so sorry. Would you mind sharing? And I'll just ask you then to...
should I go to English channel, Alex?
It doesn't matter. You just launch the presentation in English, and then Maria can launch it in Russian.
Сейчас показываю. Секундочку. Видно?
Yes, but not full screen yet. Oh, now it's perfect. Thank you. Maria, you can launch yours as well.
So, please, Marian, you can proceed. Marian, your mic is switched off.
Right, sorry. Have you got me now?
Yes, please proceed.
Okay, so thank you so much to you all, and I'm sorry about the delay. The next slide. So I'm going to talk to you all this morning and describe a study that we've been busy with for a number of years now. We started in 2013, enrolling pregnant women with rifampicin-resistant TB in an ongoing cohort. And our objectives were to document treatment, pregnancy, and infant outcomes amongst these women treated for rifampicin-resistant TB during their pregnancy. It was a descriptive cohort analysis with a record review documenting treatment and pregnancy outcomes, and then an observational clinical assessment in which we observed the children at 2 months, 6 months, and 12 months to see how they were doing after being exposed to drug-resistant TB treatment. Now, just about Bedaquiline and the new drugs, because as you can imagine, when we first started our cohort, people were being treated with the old 18 to 24-month regimen, which included the injectable. In South Africa, Bedaquiline was introduced in 2013, but limited to those only with a fluoroquinolone and or injectable resistance. This was then expanded to all those with MDR-TB. And then in 2016, pregnant women were allowed to access regimens with Bedaquiline resistant, were allowed to access Bedaquiline. In 2017, there was that rather startling announcement by the manufacturers saying that there were very high levels of Bedaquiline in breast milk. Next slide. This slide shows the enrollment in our study. So of the 4,720 participants, female patients enrolled at the hospital at that time, we were able to enroll 126 in our study. 126 were referred to us, but we were excluded some and we're left with 108 participants. As you can see in the blue, we had 108 mothers, 58 who received Bedaquiline compared to 50 who didn't. And in the green, we had 109 infants because there was one set of twins. 49 infants were exposed to Bedaquiline and 58 weren't. Next slide. I thought I should show you this slide just to emphasize that there was no difference in the baseline characteristics of the women exposed to Bedaquiline and those not exposed. So you can see we looked at age, TB characteristics, HIV characteristics, and important things like previous TB or the resistance pattern or the proportion of patients HIV positive and the baseline CD4 count. There was no difference, no statistical difference in the baseline characteristics. Next slide. So these were the maternal TB treatment, pregnancy, and infant outcomes. And you can see that mothers treated with Bedaquiline actually did much better. 71% as opposed to 62% who got the old 18 to 24-month regimen had a favorable treatment outcome. Then coming to the pregnancy outcomes, the live births were similar, 45 or 92% in those treated with Bedaquiline compared to 90% in those not treated with Bedaquiline. But the unfavorable pregnancy outcomes caused us some concern, as it was 51% in those treated with Bedaquiline compared to 43 who weren't. And as you can see, it wasn't that the preterm rate was higher, but it was the low birth weight. And if you could push the button again, Elmir, it was the low birth weight there was a statistically significant difference, with almost double the proportion of women in the Bedaquiline arm, babies having low birth weight. But of the infants that we were able to follow up after a year, there were slightly more infants in the Bedaquiline exposed group who had a favorable infant outcome, 88% compared to 80%. With 88% thriving and picking up weight normally compared to 82% in the old treatment regimen arm, and even in the developmental arm, 93% in the Bedaquiline containing arm, had normal development at a year compared to 86%. But these figures are small, and as you can see, there's no statistical difference. Next slide. So just because you wanted me to focus on bedaquiline, I've included here a slide just detailing how much bedaquiline these women were exposed to. And this slide also compares the drug exposure in those who didn't receive bedaquiline. So you can see these women were treated with drugs for a long time. And those who received bedaquiline, the mean length of treatment was 180 days. And yet the treatment outcomes were good. If we go down to, before we move off the treatment outcomes, you can see that the cure rate was higher in those who received bedaquiline. And the loss to follow-up rate, I'm sorry about that word default there, it shouldn't be there. The loss to follow-up rate was almost twice as high in the regimen, which was twice as long. So coming to fetal exposure, you can see that the median number of days of bedaquiline exposure was 77, which is a considerable number of days. The next slide, Amira. So this is some detail about the newborn characteristics. And you can see the similarity there in the live births, the gestational age at delivery. There was no difference in that, 37 weeks. But it was the birth weight that was the concern, with the median birth weight 2,690 grams in those exposed to bedaquiline compared to 2,900 in those not exposed. But coming down to the fetal and neonatal deaths, you can see that there wasn't much of a difference there. And in fact, it was slightly lower in those that received bedaquiline. 4 fetal and neonatal deaths compared to 6 in those receiving the traditional arm, with 3 stillbirths in both arms and just 1 termination of pregnancy. Next slide. Sorry, and there's the low birth weight. So we then set out to think about what could be the reason for this low birth weight? What were the risk factors associated with this? And you can see, so first of all, we looked at the maternal baseline characteristics and identified those that have been highlighted in the literature as risk factors in drug-susceptible TB treatment, as well as drug-resistant TB treatment. But there was nothing there. It wasn't the age, wasn't previous TB or the HIV status. So then we looked at the drugs that the fetus was exposed to in utero. And you can see there that in univariate analysis, it was the bedaquiline, the clofazimine, and the levofloxacin, which were all associated with an increased risk of low birth weight. Next slide. Right, so in conclusion, the mothers treated with bedaquiline, favorable outcomes were reported in 71% of the women, and 92% of the babies were born alive. Low birth was reported in more of the babies exposed to bedaquiline than in those not exposed. As I've mentioned in the previous slide, the univariate analysis showed that bedaquiline, clofazimine, and levofloxacin were associated with an increased risk of low birth weight. But after adjusting for confounders, in the multivariate analysis, fetal exposure to bedaquiline and levofloxacin had a 3- to 4-fold higher risk of low birth weight, respectively. But most importantly, after 12 months, 88% of the babies exposed to bedaquiline were thriving and developing normally, compared to 82% of the babies not exposed to bedaquiline. Sorry, next slide. So in this slide, in this table, in the first column, I've updated our comparison because our cohort is ongoing. And in this table, in the first column, the first cohort, is the cohort of 58 women who received bedaquiline that I've just been describing to you. In the second column is the cohort of 38 women we have enrolled since then. And as you can see, if you could just push the button, Elmira. As you can see, the proportion of unfavorable pregnancy outcomes and the proportion of babies with low birth weights has decreased. Although the numbers are small, and this is an interim analysis, it suggests that the new and repurposed drugs are not contributing to low birth as much as our first cohort showed. If you could just push the next button. So there's the low birth weight. You can see that it's dropped there to 31% as opposed to 45%. And then the next two buttons and the next one. Right. But, sorry, back one. So these last two buttons, the loss to follow-up rate, and then at the bottom, develop TB in the first year of life. These two indicators are very concerning. The loss to follow-up rate in the last couple of years has doubled. And then at the bottom, 3 of the 23 children developed TB as their mother was no longer taking treatment at the time of delivery. And in fact, one of these infants was born with congenital XDR-TB. Next slide. So then in 2018, we added a pharmacokinetic study component, and the objectives were to explore the effect of pregnancy on bedaquiline pharmacokinetics, to answer the questions, what are bedaquiline concentrations in pregnant women, and do they vary pre- and postpartum? And then the second objective was to describe the exposure of bedaquiline in the breast milk of mothers treated for rifampicin-resistant TB, to answer the question, what are drug concentrations in breast milk and babies exposed during pregnancy and breastfeeding to bedaquiline? So the method here was a longitudinal PK study with PK sampling at 4 time points over 6 hours in the 3rd trimester and at 6 weeks postpartum. Serial breast milk samples from breastfeeding mothers and a single blood plasma sample were taken from breastfed and non-breastfed infants to assess bedaquiline exposure. And then liquid chromatography tandem mass spectrometry was performed with breast milk and plasma bedaquiline assays and population PK modeling to interpret the bedaquiline concentrations. Next slide. So we had 13 pregnant women with both who we were able to include in the analysis, all of whom were HIV positive on ART. We observed lower ante and postpartum bedaquiline exposures in pregnant women than those reported in non-pregnant patients. But there was no difference between ante and postpartum bedaquiline pharmacokinetics. We observed high bedaquiline concentration in breast milk with a milk to maternal plasma ratio of 14:1. And then in the one breastfed infant, bedaquiline concentrations were similar to maternal plasma concentrations. And in 3 non-breastfed infants, bedaquiline concentrations were detectable, but lower than maternal plasma concentrations. And this could have implications for infant safety versus being potentially protective in infants exposed to bedaquiline. Next slide. Sorry, this is quite a busy slide, and each block represents one mother-infant pair. So here we've got 5 mother-infants to illustrate really the variation in bedaquiline concentrations. So I'll take you through all these different colors here. So first of all, the sort of orangey or red lines and dots, that's the antepartum bedaquiline concentration. And as you can see in the mother-infant pairs 1, 2, 8, and 12, the antepartum bedaquiline concentrations were similar. the postpartum bedaquiline concentrations are illustrated with the sort of purple lines and dots. And as you can see in the mother-infant pair 1, 2, 11, and 12, the bedaquiline concentrations were similar. And then if we come to the infants, that's the blue block, the turquoise blue block. You can see in mother-infant pair 1 and 12, that these are not too dissimilar. And then the breast milk is in that green, sort of lilac green. And in the mother-infant pairs 1 and 8, you can see how high the bedaquiline concentration is in breast milk. And because we had only one infant that was breastfed, our initial interpretation was, oh, the cold chain must have been broken or something went wrong. But in the BEAT study, there's unpublished data that's recently become available to some of our pharmacokinetic colleagues. And these results, these very high bedaquiline concentrations in breast milk, are being confirmed in the BEAT study. Next slide. So I'm sure all of you are thinking, how can they have been conducting this study for 10 years and they've got so few study participants? And I can't begin to describe how complicated this study is. Most of our study participants in the PK study, but in the study as well, have limited resources with limited control over their lives and often limited support. So the first problem we have is that most of them rely on public transport. Where we can, we pick them up, but it's often very complicated. So they may not arrive at all, or they may arrive late. And if you've got a PK day planned, and which takes about 7 to 8 hours, if somebody arrives at 10 o'clock in the morning with their tiny 6-week-old baby, there's no ways we can start the study then and expect them to travel home in the dark with this tiny little newborn. And then, of course, there's many issues with the medication. Bedaquiline is taken 3 days a week. So what do we do if the mother arrives on a day she's not taking bedaquiline? And then there's the complications of bedaquiline's long life and the not so long life of the other drugs. Sometimes they arrive without their medication, and it's a complicated process to go to the doctor to write for a prescription for a day's medication and then get it from the pharmacy. And then they may not have taken their medication for the last week, or a lot of them have, as Jenifer Furin mentioned in her presentation, a lot of them have problems, of these poor mothers have problems with vomiting. And no sooner have they taken their medication than they vomit, and then what do we do? What does it do for the PK sampling? Do we carry on? Do we not? And then something we had a couple of weeks ago was somebody arrived with 2 bedaquiline pills instead of 4. So we're totally unsure what happened to those other 2 pills. Were they taken, were possibly 6 taken 2 days ago? And what's that going to do? Were 2 lost, or were they taken earlier on? So they're just endless challenges with the medication. And then we've had other challenges. During COVID, I'm sure you can imagine, we couldn't say to participants, please come in, when they're traveling in the last trimester of pregnancy or with a new baby. We couldn't risk that exposure on public transport or in the hospital to COVID. The participant may arrive having been physically abused. So of course, then the PK day, we're unable to continue with that because we're so busy dealing with both the emotional and physical challenges that arrive from that. And the mother may arrive having taken no treatment for a month, and her infant is sick, losing weight, lethargic, and coughing. So often our attention is then directed to addressing the child and the problems that need to be unfolded there. So this is a very complicated study population, and sometimes we honestly feel like, although we hope we're taking one step forward, we're often taking one step back. Next slide. So just in conclusion, I'd just like to thank all research colleagues and then also all our participants and all patients with rifampicin-resistant TB and the health workers and managers who are working in these settings. And thank you all for listening.
Огромное спасибо.
Thank you very much, Mariam, for the very important outcomes of your presentation. It really makes us think. And I believe that it will be especially interesting for us to listen to the next speaker.
Идет операционное исследование по модифицированным краткосрочным режимам лечения МЛУТБ при поддержке Европейского регионального бюро ВОЗ. В рамках данного операционного исследования исследуются режимы лечения, состоящие из препаратов группы А и Б на протяжении 39 недель.
I'm sorry, Эльмира, just a second. Коллеги, пропал перевод на английском языке. Спасибо.
Так, а сейчас исправилась? Нет. Могу продолжать?
Сейчас нету перевода. Мила,
Okay,
Татьяна. Сейчас есть. Пожалуйста, Эльмира.
So I will repeat. Currently, in WHO European region, with the support of WHO Europe, we have an operational research on modified shorter treatment regimens. Over these regimens are used for 39 weeks and are comprised of group A and B drugs, including Bedaquiline. Bedaquiline is used for 9 months during the entire course of therapy. And pregnancy is not the exclusion criteria for this particular operational research. As of now, the cohort is 2,800 people, including pregnant women, and I hope that these data will serve as a basis, evidence base for the World Health Organization to analyze the data and perhaps come up with recommendations on shorter treatment for pregnant women. And as an example, we've invited our third speaker, Dr. Firuza Saidova, and she represents the operational research team in Tajikistan. She will present 2 cases from their national cohort on the operational research on modified shorter treatment regimens and they use in pregnancy. Firuza, could you please start sharing your screen? Good day, dear colleagues. Firuza, we hear you loud and clear. Let me present the Tajikistan's experience with using shorter modified treatment regimens in pregnant women. We see your screen, but we don't see the slides yet. Now we see. Could you please switch to full screen mode? And by the way, dear colleagues, I would like to remind you to leave your questions in the chat. We'll have a separate Q&A session where you'll be able to voice them. So, Firuza, now everything is good. So we would like to present 2 cases. Luckily for us, we've treated them successfully. Case number 1, a patient from a well-to-do family, a very responsible husband, and a rather well-to-do family. A woman got pregnant during treatment, during this treatment within this operational research. She's 32 years old. It's a new MDR-TB case, HIV negative, no comorbidities, but she was offered to discontinue pregnancy, but the husband was against. He was very determined to do his best to keep his wife on treatment and to have a healthy baby. She had unilateral TB. She was detected using molecular genetic tests, and gene expert revealed MTB plus RIF resistance, and LPA showed susceptibility to fluoroquinolones. And later on, we received susceptibility results to all the component drugs. And in September of 2021, this patient from the regional cohort was started on these treatment regimens. On regimen 1, 5 drugs of groups 1 and B. She tolerated the treatment well, and after the second month, she received the conversion by culture, and the rest of the cultures came back negative. But on month 4, she started experiencing some severe pains in the legs. We temporarily discontinued levofloxacin, and all the pain subsided, and we decided not to restart the drug, and based on the virtual consilium, levofloxacin was replaced with moxifloxacin, and the condition improved. On the 6th month of treatment, she got pregnant, and at month 8, she developed anemia, even though it was not a severe case of anemia, but given the early and sustained conversion and the risk of anemia progression during pregnancy, linezolid was discontinued, and she continued the treatment with 4 drugs, and the results were pretty good. She was cured. Here you see the clinical evaluation and monitoring results. You see that hemoglobin started to drop down at month 8. We discontinued the drug, and the condition improved. The patient had natural delivery at term. And now the baby is 6 months old. This is his picture. The parents didn't want their picture to be taken, but they agreed to take the photo of their patient. Now the development corresponds to the age norm, and he started getting weight properly. You see that at month 1, the weight was 4.5 kilos, at month 2, 5.2 kilos, and at present, the weight is almost 8 kilos, and development is fully in compliance with the age norm, and the parents are very glad to have such a baby. That was case number 1. Our second case, the situation is more complicated. The family is not well-to-do. The lady was in contact. Her brother had multi-drug-resistant TB. She got married, and the 2nd month got pregnant and got sick. She is 22 years old, new MDR-TB case, HIV negative, low nutrition status, also unilateral pulmonary TB. And when she sought medical care, she was at the 2nd month of pregnancy. She was offered to discontinue the pregnancy, but it was her first pregnancy. They declined, but they agreed to continue their treatment. And in August 2021, she was put on treatment regimen of 5 group A and B drugs. Here you see the microscopy results. She was smear positive and gene expert and LPA, but culture was negative and remained negative throughout the treatment. She also developed anemia, but at that time we had not much experience, and the anemia was not severe, we didn't apply to the Virtual Medical Consilium. We provided folic acid, vitamins, and also iron supplements, but perhaps we should have discontinued linezolid, but perhaps it's our minor mistakes. But in any case, everything ended well. She tolerated treatment pretty well. No severe adverse events or adverse events third for severity grade, and she delivered a healthy full-term baby. In June 2022, she finished the treatment and she was cured. So this is the family. They agreed to have their picture taken. You see, they are all happy, and the husband was also happy. Initially, they faced some challenges because initially her relatives and mother-in-law and husband didn't want to take her home from the hospital, and she had to turn to her parents. But when her husband found out that she had given birth to a healthy boy, that helped them to reconcile with the situation. So we can say that we have double success. We have cured the lady, and we have also saved the family. And now the baby is 13 months old, and he is very active and walks independently. And until the age of 3 months, he was on exclusive breastfeeding, then switched to mixed feeding. He's walking, and you see this happy child. This is the current picture of this baby boy. Thank you for your attention. If there are any questions, I will be very glad to answer them. Thank you, Firuza. I think that our third presentation couldn't have been better. It's very nice to see not only the numbers, but to see the photos of happy children. This covers the issue not only of the success of short treatment regimens, but the issue of stigmatization of people and how important is it to use shorter treatment regimens to treat them successfully. Thank you, Firuz, and I would like to thank the entire team of Tajikistan for all your work and for the opportunity you provide to the women to get treatment. Firuza in her presentation has mentioned that all the countries of the region can seek help and support in the management of patients, not only within the operational research, but also within the programmatic management and applied to Virtual Medical Consilium. In this particular case, the team of Tajikistan applied to Virtual Medical Consilium on how to manage multi-drug resistant TB during pregnancy. And therefore, I would like to ask all of you not to hesitate and seek our support. Thank you, Firuza. Our chat is full of hearts and words of gratitude to you. At that, I would like to open the Q&A session. We have some time left to voice all the questions. Some of the questions have been already answered in the chat, but I would like perhaps to repeat some of them. One of the first questions was about the use of fluoroquinolones. Perhaps it's a question to Jenifer, and Jenifer has answered in the chat, but I would like to ask her to repeat. The question is, what would you tell physicians who are a bit hesitant in using fluoroquinolones during pregnancy because of the potential effect of the fetus development?
Great. Well, thank you for the question, and thank you especially to the colleagues for such great presentations. And Firuza, congratulations to you and your team. It's really wonderful to see those beautiful families. And I think the point you made about you didn't just save a baby, you saved a family is how many of us think about the work that we're doing with pregnant people of drug-resistant TB. So a big congratulations to colleagues in Tajikistan and everywhere. When we think about the use of medications during pregnancy, we're often thinking about weighing the risks versus the benefits. And we tend to put too much emphasis on the risks, right? Where we think, oh, it could hurt the baby. Oh, it could cause these problems. And I think what we have to do is come at it more from a partnership approach. You know, we know the fluoroquinolones save lives when it comes to drug-resistant TB. These are group A medications. They're very well tolerated, and they should be offered to all people living with drug-resistant TB. So when we think about them in pregnancy, we have to ask ourselves, what would be the reason to avoid this? And there really isn't a good one. There may be less data on the safety of quinolones during pregnancy than there are on some other drugs. But in general, the data that we do have on the quinolones supports their use during pregnancy. And so I don't think there's any reason that providers should avoid the fluoroquinolones. The benefits of these drugs far outweigh the risks for drug-resistant TB. And I think, you know, that what Dr. Loveday was saying in her presentation also shows that as well. You know, that if there are risks that are associated with these drugs, they're usually manageable. And it's much worse to withhold a life-saving drug from a pregnant person because of theoretical risks to the fetus. And so, you know, what I usually do when I'm talking with a patient is I try to reassure her and any family members that are there that, you know, there have been good experiences with these drugs, that other people have been pregnant and received them, and that they've done very well, and that we'll monitor her closely. And so approaching it in that way from a partnership perspective, where we offer people drugs that are known to be associated with benefits, and then offer them the additional support that a pregnant person would need with regards to monitoring any questions or anxieties she might have or her family might have, and offering counseling is the way to go. The only drugs that I avoid during pregnancy are the injectable drugs, and then ethionamide and PAS, but I have used those medications if there's no other options. So thanks.
Большое спасибо, Jennifer. Jennifer, еще один
Thank you very much. Jennifer, there is one more question to you. What are the best practices for prevention of drug-resistant tuberculosis or tuberculosis in pregnant women?
Yeah, this is another great question. So if you have a pregnant person who's been exposed to drug-resistant TB through a close household exposure, what do we do to prevent that person from becoming sick? And right now, there's only a conditional recommendation for levofloxacin preventive therapy from the WHO. It's based on one meta-analysis of data that was done that really did not include many pregnant people. So there are 3 studies now that are ongoing looking at preventive therapy for drug-resistant TB, and we hope we'll have results in 2025. But what I usually do in my practice, because pregnant people are high risk of becoming sick after an exposure because of the changes in the immune system, is that I do talk to the pregnant person and any support people that person identifies to see if they are interested in preventive therapy with 6 months of levofloxacin. And if they are, then I do offer that to them, you know, with the counseling about, you know, the benefits and risks of this drug. Just because I feel like the risk-benefit ratio favors the benefit of preventive therapy with levofloxacin, even during pregnancy, or I should say, especially during pregnancy, because of the immune system changes. So, you know, I'm hoping that when the data from VQuin and Phoenix and TB Champ come out, we'll be able to offer DRTB preventive therapy more widely. So I do offer it on an individual patient basis after counseling and with shared decision-making. Thank you.
Огромное спасибо, Jennifer. Следующие несколько вопросов.
Thank you very much, Jennifer. We have several questions referred to Dr. Loveday. I will combine several questions. Dr. Loveday, how would you comment deaths of infants in your study? did you perform ECG to infants who were breastfed? And do you have any plans to analyze the concentration of other second-line drugs in breast milk?
Thank you for those questions. So first of all, about the ECGs, unfortunately, we didn't do ECGs in the infants. Yeah, we didn't even think of it, to be honest. Then secondly, we are hoping to look at the other drugs, especially because with the introduction of the BPEL regimens and the BPEL-M regimens, a modified, what's being planned in South Africa is a modified regimen in South Africa. And again, it's new regimens that pregnant women have not been exposed to before. So we're just going to carry on monitoring and see what happens. The plan is in South Africa that pregnant women will not get protominid, but will get delaminid instead. So what we're hoping to do is look at Bedaquiline, linezolid, because of course linezolid is always such a problem because of the resulting drop in hemoglobin levels. So I hope that's answered the questions.
Thank you very much. There was another question that is actually a continuation of the previous ones. What is your expert opinion on whether it is worth providing preventive treatment to infants who had contacts with mothers with MDR-TB? Although the results of pharmacokinetics show that Bedaquiline can affect infants through breast milk. And do you believe that if mothers receive Bedaquiline, it would be better to switch to formula instead of breastfeeding? So this is a question to both speakers, Marian and Jenifer.
Jen, are you happy if I go first? I'll answer the easy bit and then you can answer the difficult bit. I'll answer the question about the formula feeding and leave Dr. Furin to answer the question about preventive therapy, because honestly, I don't know what to say about that, given how little we know about the concentration of the second-line drugs in infants, either if they're not breastfeeding or they're being breastfed. So coming to formula feeding versus breastfeeding, I think it depends on the situation of the family and has to be discussed with the family. Often in our setting, formula feeding is not such a simple option. Running water is not available in the house. It might well be necessary that all water is boiled before it's added to the powdered milk. And of course, that's expensive. The powdered milk is expensive. So can the family actually afford to safely feed the infant formula feeding? Also, we've got to remember that human breast milk has so many other advantages. So I remember many years ago when at the start of the HIV epidemic in South Africa, because we have a very high proportion of pregnant women in particular who are infected with HIV, that breastfeeding was initially recommended that breastfeeding be stopped and all babies get given formula feeding. And then because of the risk of transmission, but then the guidelines changed because of the advantages of breastfeeding in a situation like ours where resources are limited. So, but it's really a discussion that the attending clinicians need to have with the family, and because every family is different and what they want to do, what's expected of them, and what their hopes are is what is important and how best those can be realized. So, Dr. Furin, I'll leave the rest to you.
Thanks, Dr. Loveday. You know, the issue of preventive therapy for the neonate is a challenging one. I think this is one of the reasons why it's important to start the pregnant person with drug-resistant TB on the most effective treatment as quickly as possible, and why shorter regimens are especially beneficial during pregnancy, because oftentimes you can be close to or have completed the therapy by the time the infant is born. So as our colleagues from Tajikistan showed, you know, these women were negative, smear negative, culture negative, and doing really well at the time that they delivered these infants. And so the risk of transmission to the infant is quite low in that setting, provided the pregnant and peripartum person is able to stay on therapy. And so I think that's the first key. The second key after the neonate is delivered is just to make sure the neonate is healthy and doing well. And if the neonate is healthy and doing well, many of us do offer preventive therapy, again, with levofloxacin for 6 months. A lot of us were taught that the quinolone shouldn't be used in